All right. Hello, everybody. My name is Christy Noonan. I am the program director for general surgery at Jefferson Abington Hospital. If you are reviewing this video, you are likely were invited to come to an interview at Abington for the general surgery residency. So I put this together to provide you with some sort of background information on our program. At the conclusion of our interview season, we will have this video posted on our website so that folks going forward in the future can review this while they're investigating programs they might be interested in. Hopefully my screen share will come up here. All right, good. So we have gone through some rebranding over the years. For like 111 years, we were known as Abington Memorial Hospital. A couple decade ago, we merged with the Jefferson Health Network and were rebranded as Abington Hospital Jefferson Health. And then most recently, the rebranding, we are now called Jefferson Abington Hospital. This can be a little confusing for folks. Changing the name is hard in some of these recruiting programs like ERS and the AAMC. So you may see different names used by the NRMP or by ERS. But there's only one Abington hospital with a general surgery residency program. So that is us. I have interspersed in this talk a little bit some of the very commonly asked questions that we get during recruiting season. So hopefully we can at least preliminarily give you some information on those questions so that you can either come up with new questions that you want answered, or you can sort of dig deeper into those things when you come for your interview. So Abington Hospital, just so everybody is aware, is not a little small community hospital. This is Abington Hospital. It is an enormous place. It is well larger than a city block. And like most hospitals that have grown over time, our local population has grown, population density has grown, and along with our community, our hospital has grown. So all of these buildings were sort of built at different points in time. They are all obviously interconnected on the inside, usually on different floors, just to make things complicated. But everything on that north side of the street is all Abington Hospital. You can see just across straight through the middle there, 611. On the south side of the street is the Levy building. The Levy building has some offices, including some general surgeon offices, as well as an outpatient endoscopy center that we utilize. There is plenty of parking on site. So where is Abington located? We are very, very close, but not quite in Philadelphia. Philadelphia city and county is quite extensive for an actual city geographically. We are about 4 miles from the border, the north border of Philadelphia. This is the view from the window on the 6th floor of the Price building, which is where my office is. And you can see the skyscrapers out there in Center City. As the crow flies, it's about 13 miles directly into Center City, like from us to Thomas Jefferson University. Practically, what does that mean? It means that it's relatively easy to get downtown when you want to get downtown, but it's far enough away that we're a little more suburban. There are 2 regional rail train stations located within about a mile of the hospital. And if you want to get downtown on the train, it's about 20 minutes on the train. If you're driving, obviously depends on the time of day. It can take anywhere from 25 minutes, which is what the residents tell me when those that live in the city are coming up. Or if you want to do it during rush hour, it can take a solid hour and a half. At any given time, about 45-50% of our residents do choose to live in the city. I get it. You're young and, you want the social activity of being in the city. So certainly that can be done. But the hospital is located in a much more suburban area. Lots of parking lots, grocery stores. There's a Costco and a Sam's Club and all that kind of thing. So much more suburban. Practically, if we look at a map, so I know it's kind of hard to see, but there's a little red dotted line that you can see sort of moving around up here. It's kind of jagged and jumping around. That's because it follows some rivers and some state roads and things like that. But that is the northern border of the city of Philadelphia. You can see that we up at the top there at Abington, there's an orange star. That's where the hospital is located. So we're relatively close to the northern border of Philadelphia. That blue dot in the middle there, that's important because that's my house. And the residents do spend a fair bit of time in my pool in the summer. And then up at the top here, you can see just sort of barely cut off the screen is Fort Washington. Fort Washington is where our sister hospital, Lansdale Hospital, is located, and the residents spend, it's about 13 miles there as well. Residents spend some rotations at Lansdale. But I show you this map so that we can talk a little bit about patient population. So we out here in the suburbs have a relatively affluent community. It's a very safe place to work. You won't really get in trouble on the way to work or walking to your car late at night, things like that. But we draw from a much larger population. The northern end of Philadelphia, around near Jefferson Einstein Hospital, is a much more socioeconomically depressed area. And so there's a lot of patients there who maybe don't have as much access to healthcare, don't have issues with insurance and coverage and things like that. Jefferson Einstein, while it is part of the Jefferson network, and they do have a standalone independent residency, that hospital is really kind of a safety net hospital. It provides a lot of acute care, but a lot of folks prefer to move north to Abington when it comes to more elective stuff. And so for that reason, we are a not-for-profit community hospital that takes all comers. And so we do get a significant amount of delayed disease presentation, as well as complex elective stuff. The elderly population in our neighborhood is significant. And so we see a lot of people with advanced vascular disease and advanced oncologic presentations, things like that. The ethnic mix is quite diverse. Along 309 here, which is the closest border to Philadelphia, there's a very diverse multinational community down there. I'm told that Philadelphia has one of the best Koreatowns on the East Coast. There's a lot of Korean immigrants that live along that road, so lots of good Korean food, but those folks also tend to come to Abington. That's our third most common non-English speaking population. Also, a significant West Indian population lives there. A lot of Southeast Asians live there, and so that community tends to present to Abington Hospital. Over here in the Northeast, Philadelphia, that's where I used to live. That community is very blue collar. There's a lot of tradespeople who live over there. There's a large Russian population and Ukrainian population that live over there. There are some Jefferson hospitals sort of up along Route 1, but they again tend to have limited services. And so a lot of those patients either end up presenting at Abington because we are the flagship hospital for the North region, or a lot of times they're getting transferred for things like ICU care, bariatrics, stuff like that. So a little bit about our shop. We have currently 665 beds. They just converted both the pediatric unit and the inpatient psych unit into active med-surg beds because our hospital is always bursting at the seams. While our hospital is not the biggest by beds in the Delaware Valley, which is kind of all of the Philadelphia region, we are very commonly the highest number of staffed beds. Nearly all of our beds are staffed nearly all of the time. And there's very commonly folks, awaiting placement in the hallway in the emergency room. We also have an additional 140 beds down the street at Lansdale. They also have relatively limited services. And so we do see a lot of patients that are moving back and forth for either ICU care or IR or services that are not provided at Lansdale. We have 24 operating rooms. That includes one current hybrid OR and one that is approved and funded and awaiting the start of construction. What is a hybrid OR, you might ask? A hybrid OR has interventional radiology or live x-ray capabilities. And so that means those are the rooms that our vascular surgeons spend a lot of time in doing their endovascular work. And additionally, if a trauma were to come in that we wanted to try and manage minimally invasively using IR techniques to embolize things or things like that, those emergency trauma cases go to a hybrid OR so that the IR team can come up and try and do their work. But in the event that the patient crashes and needs, to be opened, they're in an operating room for that to happen. We are the robotics center for the enterprise, the Jefferson Enterprise. We have 5 Da Vinci robots on site. 4 of them live at Abington. 1 of them lives over at Lansdale. They are pretty much continuously in use. Please note that all of our robots have a teaching console. And what that means is that the attending surgeon and the surgeon trainee are sitting side by side next to each other at the training console, and the attending surgeon has the ability to push a button and transfer control back and forth between the learner and the attending. So it's not that the residents are getting robot cases by watching at the bedside. They are physically at the console, operating with the surgeon. We have 92 critical care beds distributed across a variety of ICUs. The surgical ICU, which is basically staffed by us, that takes all of our trauma, takes all of our general surgery, vascular surgery, thoracic surgery, all that kind of stuff. We also provide critical care services for the subspecialties as well as OBGYN. So you get a broad critical care experience. There's a relatively large MICU. There's a cardiac surgery unit as well as a cardiology ICU. And then we have special beds that are reserved for the ECMO program as well as the LVAD program. So there's some pretty advanced cardiothoracic stuff going on in the building. We do about, under our roof, just the Abington roof, 14,000 operations a year. More and more stuff is being moved to the outpatient arena. And so I think the volume at the surgery centers is bumped up a little bit and the inpatient volume is bumped down a little bit. That's still a pretty good number under one hospital's roof. About 5,000 of those are general surgery, which of course we cover. And then the additional vascular, thoracic, those kinds of things we cover as well. Our surgery centers, we have 2 of them, the Abington Surgery Center and the Huntington Valley Surgery Center. Abington Surgery Center is about 5 miles away. Huntington Valley is about 5.5 miles away, so they're not too hard to get to. The residents are traveling out to them to work with our faculty. That's about another 7,000 operations a year. Our OBGYN department is quite busy. They also have a residency. They are delivering more than 5,000. I think they're aiming for above 5,000 for this academic year. 5,000 deliveries a year, which is huge. That's second in Pennsylvania only to the Women and Children's Hospital in Pittsburgh. We see about 34,000 admissions a year. Our emergency room is hopping. They're actually looking to expand the emergency room to try and figure out how to stick more beds in there. We're seeing more than 100,000 visits a year. We are one of only 2 trauma centers in Montgomery County. Montgomery County is the county just north of Philadelphia County. Philadelphia County is essentially entirely encompassed by the city of Philadelphia. But Montgomery County is the 3rd most populous as far as population density in the state of PA, behind Philadelphia and Delaware County, which is a very small county. So there's, lots of stuff going on right here, but it's also one of the most diverse counties in PA, not just socioeconomically or by ethnicity, but the spread of urban to rural. Obviously, you saw from the map that we are really juxtaposed with highly dense urban city just a couple miles from here. But if you go north from here towards like Hershey, it gets really rural really quick. Out there, it's, dairy farms and cornfields and things like that. So it's in a relatively small geographic area. Quite a diversity of patients and the problems that they bring. So what kinds of programs do we have here as far as education? So there are 5 primary residency programs. General surgery, that's us. We currently have 31 learners, and I'll come back to that in a minute with the breakdown. The OBGYN program, again, super busy. They just expanded. They're up to 24 residents, 6 per class. Internal medicine is huge. They have 63 residents total. There's a standalone family med residency. They live in their outpatient offices about 3 miles from the hospital, but they do spend some time in the hospital, both in the HeartNet clinic as well as they have an inpatient service where they take care of their own patients. So we do interact with family med. And then we have 2 pharmacy residents who are very integrated into our teams. They help us, especially in the ICU. They round with the ICU team and help make decisions on complex polypharmacy. Sadly, we just lost a dental residency. We had 2 dental residents, but that program is now being closed. There's a handful of fellows around, really kind of the only one that has much of any interaction or competition with the surgery residents is the bariatric fellow. That's my fellow. I will say this, the bariatric program is quite busy, one of the busiest programs around, and there are nearly always two rooms running in bariatrics, which means there's one room where the fellow is usually working, and then there's another room where the surgery residents have access to bariatric cases. So they're usually not competing. And when the fellow goes out of town, like last week, we have significant challenges in getting all the bariatric cases covered, given everything else that's going on in the building. There's some other folks around, the geriatric fellows. So we have the second highest nonagenarian trauma population in the country. There's a lot of very elderly folks in our neck of the woods. And so we work very closely with the geriatric fellows, particularly on the trauma service, trying to improve safety in both in the hospital and after they leave the hospital for our geriatric population. There is a neurointerventional fellow. There's two of them. They are imminently available to help manage things like strokes and emboli and aneurysms. And then we sometimes co-manage those patients with them. And then there's a pulmonary fellow that's shared with some of the other hospitals in the enterprise. And that pulmonary fellow enables or motivates the pulmonary department to do some complex interventional pulmonary work. So all told, we have about 150 learners at the GME level who are housed in our building. Beyond that, there are a whole lot of rotating learners. We have learners from Jefferson rotating, residents rotating in things like urology and orthopedics. There's advanced practice students, nurse practitioners, and PAs coming from a variety of places. There's med students from everywhere, all over the place, nursing students from everywhere, all over the place. So there's quite a lot of learners around who are visiting or rotating with us. So to introduce you to the crew, this is me. Again, my name is Christy Noonan. I'm the program director. This is my third year as the program director. That being said, I came to Abington just out of training in 2011. So I've now been here, it'll be 15 years this next summer. And for the majority of that time, 12 years of that time, I was an associate program director. And so I worked with multiple chairmen over that time. I worked with multiple program directors over that time. So that transition was relatively easy for me because I really have been deeply involved in the program for a long time and know, kind of how it works, what things work, what things haven't worked, and have some institutional memory to know how we've tried things before. While I mentioned that, I'll also say that the previous program director, Dr. Robert Josloff, had been the program director for 8 years before I stepped in. And I think it's important that Dr. Josloff did not leave. He did not retire. He's still on faculty here in our residency. He's still very clinically busy. He's a robotic hernia surgeon by trade. So he's continues to operate with the residents, continues to be very invested in the program, in the educational objectives, and working with the residents and making sure everybody's successful. But also I appreciate the fact that Dr. Josloff is still around to provide some mentorship to me as a relatively new program director and get his perspective on things. So I'm originally from Chicago. I went to U of I for med school, came out to Philly in 2003 to do my residency at HUP. If any of you are from Philly, you'll know that once you come to Philly, like nobody ever leaves. Everybody's stuck here forever. So I've been here ever since. I went away for a little bit and did my research in Harvard, in Boston, and then did a year of fellowship in MIS and bariatrics in Wisconsin, and ended up coming back to Philly. Like I said, I've been at Abington since 2011. I apologize if this video is a little bit delayed. I've been kind of procrastinating on it because I really was hopeful that I could have something to put on this slide. Dr. Curtin was our chairman of surgery. Dr. Curtin concluded his contract at Abington Hospital at the beginning of this academic year in July. And the selection committee has not quite nailed down the next chair of surgery. I can't give you a lot of information about it other than to say that they're very close. And I think we'll be pleased when the contract is signed and the ink is dry. That being said, in my residency time, I think they changed chairs two or three times. When you have a program that's as well established as our program is, that's been here for as long as our program is. It's been integrated into the hospital and then has a strong leadership team beyond the chair that have been there for a long time. I really don't think much could go wrong with the hire of a new chair. I think having a new, fresh set of eyes and new energy and new ideas of ways to do things can only bolster the program. The rest of my team includes Dr. Jackie Malici. Dr. Malici is an associate program director. She got her DO from PCOM, which is right down the street from us. She did her residency here with us at Abington, went to HUP at Penn, did a very elite 2-year vascular fellowship, and then came back to Abington about 3 years ago now as her first job out of training. And immediately, wanted to be an associate program director, wanted to be involved in the educational administration. I will ask you to notice as we go through these slides, or if you go through our website, how many of our faculty are alumni of our program. And I think that is an important thing to note, should tell you something. And also note that most of these people did not stay here by default. They went away for their fellowship or they went away for another job and they ended up coming back here. I think that speaks volumes as to the environment and the collegiality of our program and of our department and of our hospital, that so many people come back after finding out that the grass is not always greener. Dr. John Fu is my other associate program director. He is Canadian originally. He got his medical degree at Michigan State. And then John just decided that he wanted to go out into community practice. He did not feel that he needed a fellowship. He wanted to do bread and butter general surgery. He took his first job out of Abington at Lansdale, which is our sister hospital down the street. He does a fair bit of complex robotic work, mostly hernia stuff over there, as well as taking ACS call. And in the last couple of years, he's been promoted to be the chair out there. So he is also the site director for the residents while they're over there, and works closely with them there. Dr. John Jacob was named, when I took over as program director, he was named the director of surgical simulation. I transferred that title to him. John is originally from the Philippines, got his medical degree there. He actually came to us as a PGY1 prelim. We have a strong reputation for accepting international medical grad prelims, and not uncommonly do we end up taking them into the program as categorical residents. So John was kept as a categorical, completed the program here at Abington. He went on to do 2 fellowships, one at Penn, at HUP in surgical critical care, and then his second one was in thoracic surgery at Montefiore. He also went out and practiced for a few years. He was up in New York, and I want to say it's about 3 years ago now, he came back to Abington, where he's been rapidly building a busy thoracic service. And most recently, Dr. Francesca DeLatch. DeLatch was originally from Southern California, got her medical degree at USC. She's also a graduate from Abington. She went and did her fellowship at Bryn Mawr, which is local, in breast oncology, and then was in private practice for several years. Has recently, in private practice at Abington for several years. A couple of years ago, became employed at Abington, and just recently has taken over as the medical student clerkship director. So she runs the Jefferson students, the PCOM students that rotate with us, as well as the sub-I program. At any given time, just going back to the prelim thing, at any given time, we usually have 2 to 3 folks in the program who started out as prelims with us. So that's something that we are known in the business for, is keeping our own prelims if they turn out to be exemplary. A little history about us. As I mentioned, we've had a program here for a very long time. I'm actually in the midst of writing a paper about the history of Abington surgery. But the general surgery residency program was founded in 1956. So this is really our 70th anniversary. It's been pretty stable at the size that it's at. We expanded, like the year I got here, we expanded to 5 categorical residents. So we now have 5 per class. We also have 2 prelim PGY2s were added in 2021. And then we take 4 preliminary resident PGY1 prelims per year. So it's a total of 31 residents each year in the program. Little history about our adventures with Jefferson. Abington had been a freestanding hospital and residency program for quite some time. There was a merger with Lansdale, sort of before my time in like the late 90s. They became our sister hospital. We were Abington Health. Around 2015, we did a hub to hub merger with Jefferson Health, which was one of the major health systems in the region. It was not an acquisition, it was a hub to hub merger. And that brought us into contact with both Thomas Jefferson University and the Sidney Kimmel Medical College. Their flagship hospital, their big university hospital is Thomas Jefferson University Hospital. We started becoming more involved with them and sort of streamlining care and developing enterprise-wide service lines to make sure that all the care across the enterprise is provided in a relatively standard fashion that is best practice. There is an 86,000 square foot cancer pavilion. It's actually close to us. It's just north of here, just north of the Turnpike, that was built before the merger. It is a NDI designated cancer center. There are only 70 NDI designated cancer centers nationwide. And the good news is because it's closer to us and because folks out here in the suburbs don't want to go into the city, quite a lot of the oncology work that comes out of Asplund is brought to Abington rather than going all the way down into the city. Nobody wants to go, drive downtown into the city in rush hour, pay $50 to valet your car to visit their loved ones. They'd much rather go to their community, to the hospital that's in their community that can provide care at the same high level. Along with all of these integrations, the good news is we get access to a lot of the resources of a university without having to be the university. And so in particular, I'm talking about research opportunities. We have, because of this relationship, we have the opportunity to do research at multiple sites. We have opportunity to collaborate with other teams. In bariatrics, my practice has our data, but if we can expand to include the data in other practices, that certainly gives us much more powerful statistics to work with. It gives us introductions to experts in different areas if we need folks to collaborate with. It's just really broadened the reach of Abington significantly in a lot of different ways. And then they have all the sort of ancillary support services for research. So in particular, statistics. The IRB now works out of Center City, works out of the university. And so all those things kind of got streamlined and provided new resources to us that we may not have had in the past. Again, along with the university, they have an innovation pillar, which is looking at sort of bringing together folks in different fields to collaborate on things to improve care. Not too long ago, Jefferson bought up the Philadelphia College of Design, which includes some things around, some opportunities and some specialists around things like internet design and graphic design and coding. There's even some engineers over there. And so if there's something that you're interested in working on, there are ways to reach out to specialists and something like that could help you or collaborate with you. Also, there's a huge graduate school down there. And so as surgery residents, you're considered instructors in the Sidney Kimmel Medical College. And what that means is that you get basically faculty rates if you want to pursue additional education. Now, that's not for everyone. Like, when you're working 80 hours a week and you're really tired and you've got a family at home, it can be difficult to put the time in. But the cost is very, very low. In fact, I'm taking an advanced degree or advanced certificate program right now, and it's like less than a couple $1,000s to do the certificate program with the tuition reduction as well as the tuition reimbursement of being faculty. Over the last, maybe 5 years, we've had a couple of residents who've gotten master's degrees. One got a master's degree in clinical informatics and went on in his first job after Abington, after his fellowship, is now the CMIO of a hospital out in Nevada. And then another resident got a master's degree in healthcare quality and safety and is a chief quality officer at his first hospital. Other benefits of the university is they do a couple things that we don't do. Most importantly, transplant. We don't do any transplant at Abington. You need a lot of resources for that. And there's already a lot of transplant programs in Philadelphia. TJUH has a big transplant volume of kidney and liver. They also do a fair bit of pancreas, and their outcomes are very, very good. And so we do send our residents downtown for a transplant experience so that they can get their hands on that, and that augments our HPV experience a little bit. There are in our very big enterprise, it just like doubled in size last year, for independent residencies. Us, obviously, Abington. Center City is the university program downtown. Einstein, you saw on the map where Einstein lives in North Philly. And then we just in the last year have started the process of merging with Lehigh Valley Health System. Lehigh Valley has its own surgery residency. I would say it's about an hour, maybe an hour and a half north of here. And that came with 17 other hospitals that are part of their health system. So we're just sort of starting the process of integrating with them. Every time they buy up a new hospital, we have to like reintegrate. But it provides an opportunity for us to look at, what, especially educationally, what resources they have, what specialists they have. Are there any cases maybe that we want to take advantage of? Do any of their residents want to come down and share opportunities with us? We go up there and do a cadaver lab. So it just sort of runs our reach and opportunities that are available to us. So what do we have here in our shop? As I said, we are very suburban. There's lots of parking lots. There's malls, what's left of malls, grocery stores, big box stores, stuff like that. So whatever you want to find, you can find it around here. It's not like concentrated urban living where you have to take the subway everywhere and parking costs $1 billion. There's an affiliated childcare center across the street from the hospital. It's right next to the Levy building. It actually opens very early in the morning and closes very late in the evening, specifically to allow for healthcare workers' schedules. So that's a resource that's available. As I said, Lansdale is about 14 miles away. ASC is about 4 miles away. Huntington Valley, I think, is like 5. And also the vast majority of our surgeons' outpatient offices are on site, meaning on campus, you can walk to them. Some are in the medical office building attached to the hospital. Some are in the Levy building across the street. There's a handful of us that have offices out in the community. I think probably the farthest one away is mine, and that's like 6 miles away. And we're getting ready to move to a place that's like 3 miles away. So really everything you need is quite nearby. We have a newly renovated surgical resident resource room. What is that? That's like their home base. That's where they live. That's where they hang out. That's where they dump their stuff and hang up their white coats. It is nice when it's clean, when they clean it. It is very conveniently located on the floor where our main surgical floor, where our patients live. So instead of being across the building and having to run when somebody needs help with something, the residents are right there on the floor where the patients are. And there's a couch in there and a kitchenette in there, and then a bunch of workstations so they can work. And there's a big TV with a Zoom link in there, which is supposed to be for Zooming into conference, but I understand is mostly used for watching Harry Potter on Saturday night on call. The chief residents have their own office up on the 4th floor. That gives them some more space to spread out and kind of keep their stuff in order to get through their administrative duties as well as their research stuff. We recently renovated the call suites. There's one in the ICU, so that the ICU resident is right nearby when needed. And there's one on the surgical floor so that the floor intern is right nearby when needed. In these call suites over the years, we've determined that because we're not really doing a lot of 24-hour shifts, we didn't need as many rooms with beds as we used to have. So we've reworked those spaces and put some workstations in order to allow the residents to have more sort of protected space off the floor. The nurses' stations sometimes get very busy. There's, nursing and nursing students and the hospitalist coming through and social worker and whatnot. And it's like hard to camp out and like leave all your stuff there. So this provides some space for them to be off the floor. It's behind a door that you have to badge through. So it's just for them, just for our residents. They can leave their stuff in there if they want to. And then we have one that's kind of a nicer room that is in a quiet spot so that it can be used for interviews. The chiefs that are doing interviews right now for fellowship can use that space so they don't have to run home and change into a suit and then change back and then come back to the hospital. They've got some space in the building. They just renovated, GME just renovated a bunch of basement call suites. We hadn't used them in many years because they were needed to be renovated, but now they are. We have 5 rooms down there. And so we are just sort of talking about what we want to do with that space. If we want to make that space into additional educational space or storage space or what. I'm going to come back later and talk about the HeartNet Health Clinic, but they just did an $8 million renovation of that clinic. That's our space. Again, we're a not-for-profit hospital, and so we have a community health mission. That is the clinic that provides services, both medical and surgical services, to uninsured and underinsured folks. Really nicely redone. It was all philanthropy money. So now the medical team that lives there pretty much every day, they have their own space. The specialist services like surgery, we have our own space, and there's a lot more space for us to work together. So that's been really, really nice in the last year or so. They just finished building out a mini mart, which is kind of like a 7-Eleven in one of the hospital lobbies. There was concern that the cafeteria closes at night, and so sometimes the night shift team has limited option to food. So this mini mart has, snacks as well as, stuff that can be heated up, and you can badge in and just sort of swipe your badge to pay for things. We recently installed refillable water bottle filling stations. Each resident room has one, so the surgery resident room has one, so they all carry around their little Yetis, are able to refill their water bottles, and then all the residents get meal credits on their badge for the nights that they are on call at in-house. Lastly, we have a big focus on wellness, and there's lots of things that contribute to our wellness sort of curriculum. We have puppy therapy. One of the administrators in the emergency department is like on the board of directors for a local animal shelter. And so she often, especially in the spring, brings in puppies to the ER, and you can basically go check out a puppy. The puppies don't hang out in the ER, and they're usually out, roaming around the building in somebody's arms. And there's certainly nothing that will brighten your day faster than a couple of minutes of snuggling with a little puppy. A GME office is also very active. While they live across the street in the Dixon building, they realize that nobody's ever going to go to the Dixon building. So they're usually on parade around the hospital. They just recently did reverse trick-or-treating for the residents. So knowing the residents weren't going to go to them, they brought candy to the residents. They run the gingerbread house contest at Christmas and other things like that. There's a robust DEI committee. They are also usually out and about providing support and activities and things like that. And then there's a wellness committee. A faculty member who's a social worker in family med is the chief medical officer for wellness for GME. And then each residency has a wellness chief. So our wellness chief plans activities and tracks time off and things like that. So here's an example. You can see at the top here, this is actually the clinic staff running around with the puppies. It's, puppies are first come, first serve. So you got to get there early if you want to run around with a puppy. And the bottom right here, you can see 2 of our nurse practitioners, as well as a former chief, Tashara, picking up coffee cards from the DEI committee on Juneteenth. Additional resources available for our trainees. This is our surgical simulation center, our skills lab. I built this. As I said, I just gave the title away not too long ago. So this is close to my heart. It is located, I counted, 21 steps away from the resident resource room. So it's right there. I found from historical experience that if the sim center is on the other side of the building, or even worse, the other side of town, nobody's going to use it. So this is our sim center. It's right there on the surgical floor. It contains several FLS boxes, which I'm sure you guys have seen before, for like very basic laparoscopic training. There's also a box in there called Atlas, or advanced training in laparoscopic suturing, that allows you to move the camera around in the box, basically, so that you can practice off angle work and suturing under tension and in confined spaces and things like that. We just acquired last year about this time our standalone robotic Da Vinci simulator. You can see it in the top right there. It works exactly like the robot works in the operating room. There's a whole there's a required curriculum, but then there's a lot more, a whole library of additional skills that you can practice if you want. Um, Specifically, we advocated for this standalone simulator because our previous simulator was a robot backpack, which means it was attached to the back of a machine, a robot that was in an operating room. And the problem with that is the robot runs all the time. There's always somebody in there operating. So the only time we could get available for residents to train was nights and weekends, which is a wellness/duty hours problem. So after quite some time of advocacy, we just acquired this standalone simulator. It is not located in the sim lab. It's actually down in the operating room, like in a closet in the operating room, so that other folks who don't have access to our sim lab, like faculty, can get access to the robot trainer. But it is very frequently in use. Pretty much every time I walk by, there's somebody in there practicing. And I've heard feedback from our robotic faculty that the degree of resident participation and entrustability in cases has gone up dramatically for those who are willing to put the time in on the simulator. The sim lab also includes some high fidelity VR machines. The lab mentor is for junior residents to start working on their laparoscopic skills, learning things like targeting, eye-hand coordination, fulcrum effect, things like that. I'm always advocating that the more time you spend in simulation, the more effective the time you spend in the operating room. Nobody wants to be in simulation when they could go to the operating room, but if you do the simulation when you're in the operating room, you get to do more. There's also a VR endoscopic trainer in there for both upper and lower endoscopy as well as bronchoscopy, which is utilized by the thoracic service. Just to make the point that the endoscopic trainer is the exact machine that the FES exam, which is required by the Board of Surgery to sit for your surgery boards, that's the machine that the test is done on. And the module of the test is on the machine, which means you can basically practice on the exam. And very few programs actually have that. It's quite an expensive thing to buy. Very few programs have that. So that's a huge advantage that we have that under our roof. In fact, the other surgery residencies in the enterprise tend to come to our shop to use it because we're the only ones that have it. And at the bottom there, you can see we snagged a retired tower, real life tower from the operating room, and hooked it up to a trainer box. So that allows you to do some of the things that are challenging in an FLS box. You can move the camera around, you can change the angles, but also it allows some education around troubleshooting of the equipment. So what do you do, when your light source doesn't work, or what do you do when you have an insufflation problem? Those are things that we can run through drills on the real life tower. Sorry, going the wrong way. So what do we do? I imagine this is going to look pretty similar to what everybody else out there is doing. These are the requirements of the Board of Surgery. But importantly, I want you to note that 85% of our rotations are under our roof. And what do I mean by our roof? Our roof, as far as I'm concerned, are the things that were historically Abington. That means Abington Hospital, Lansdale Hospital, I'm sorry, not Fox Chase, the Abington Surgery Center, and Huntington Valley Surgery Center. All of those places are places where the Abington faculty go, and that's under our roof. There are some rotations where we have to go out for a variety of reasons, but I would like you to notice in looking at this list that if we have to go out in general, we're going to a pretty premier spot. For example, pediatric surgery, we send them for 8 weeks to CHOP. The Children's Hospital of Philadelphia is one of the best children's hospitals in the world, like full stop. So you're going to learn pediatric surgery. Why not learn it there? For surgical oncology, we do some in our house. We do some at Lansdale. But we also have specialty rotations at Fox Chase Cancer Center, where they're doing a lot of HIPEC, melanoma, sarcoma, things like that. And we have the PGY4s go for 8 weeks to MD Anderson, has an outpost in Jacksonville at Baptist. So they spend 8 weeks in Jacksonville, which is a little bit of a hardship to be away. However, again, you spend most of your time under our roof. And while they are in Jacksonville, they are the only learners in that building, which means beyond the HPB cases that they go there to do, they also have their pick of, GU cases, gyne cases, head and neck cases. In fact, last weekend, I got some texts because the surgeons were fighting over, who got the resident in their room. And the bottom line is the resident gets to choose. So it's a great experience for them to be the only learners down there. And then we go to TWH for transplant, as I mentioned before, and I'll come back to Hartnett. going back to 85% under our roof. The reason why I think that's important is that, and I try and protect that, is that when residents get really distributed, when they're spread out over a lot of places with different faculty at all those places, I think it dilutes the experience a little bit in that, um, it's harder for the residents to figure out what exactly the faculty want them to do. And it's harder for the faculty to get to develop enough trust with the resident to really give them a lot of autonomy. So the fact that we spend that much time with our faculty makes it really a pretty close-knit group and sort of maximizes the amount of autonomy that they get. Our rotation sites you can see here, it's on the website too. The PGY4s all get to do 4 weeks of an elective rotation of their choice. Most of them use it as an opportunity to do either an audition rotation at a place where they think they might want to do their fellowship, or they're basically looking for a big name letter kind of thing. We've really placed some folks in some terrific away rotations. Bariatrics with Aurora Pryor at Stony Brook is like a premier bariatric rotation. We've had a bunch of folks just recently. One of mine came back from Penn doing trauma. Last year we did CT surgery at Penn. We've had a very strong relationship across multiple levels with both Cleveland Clinic, Ohio, and Cleveland Clinic, Florida. We now have some faculty at some of those places too. So wherever you want to go, we can usually get you a spot there. But these rotations are not just to burn time. Basically, we will tailor this experience to what you're looking for in your career. This past year, one of our residents is very interested in going into private practice. And she really felt like she wanted to spend that time learning how to run a private practice. So she did her 4 weeks as a preceptorship with one of our breast surgeons who has run his own private practice for like 30 years. And they went over the books and they talked about contracting and all that kind of stuff. Another one of the chiefs this year has a very significant interest in historical experience with policy and advocacy. And so she actually arranged her fellowship time around going down to Jefferson and working with the injury prevention team down there, and has since been named a director of their injury prevention team, is coordinating research and advocacy efforts between downtown and us. So really that time is designed to be tailored around what you need for your career. The educational program. So like everybody else, we have mandatory core educational conferences. We do a conference from 7 to 8 every Wednesday. On Thursday from 7 to 8 is M&M. Then there's half an hour of team sign out. And then from 8:30 to 10:30 is protected didactic time. And when I'm talking about protected, it's for real protected. The advanced practice team takes all the calls. In fact, I tell the residents to turn their phones off. I don't care who's epic chatting you. You are in protected time. Any emergencies happening out there should be handled by APCs and the faculty. So what do we do during that time? Obviously, M&M we have to do every week. In fact, I'll get to it later, but you guys will be invited to M&M. Each service, we try and get weekly service-based clinical conferences. So the vascular has a meeting every Monday. The bariatric team has a meeting every Wednesday, where we, do some textbook teaching or case-based teaching. We do a lot of work around mock orals. The oral exam in surgery is usually something that people have never seen before. And we find that everybody finds that the reason people fail their mock orals is mostly because they've never practiced the exam format before. Talking through your judgment, talking through decision-making, thinking out loud. So we do a lot of practice mock orals because the literature shows that the best way to prepare for your orals is to practice for your orals. So we do that with both our faculty and visiting faculty, and we participate twice a year in a multi-institutional mock orals with all of the other programs around us. We do quarterly grand rounds with a visiting professor, Dr. Frank Spitz, who's the chair at Cooper and a surgical oncologist. He's the deputy chief at MD Anderson Cooper, just came on Thursday and gave us a talk about resectable pancreatic cancer. We do some lectures and professional development around professionalism. We have a pretty robust, I also wear the hat of being the director of surgical quality and safety. So we have a pretty robust quality curriculum as well as research curriculum. And then both with our faculty internally, as well as our faculty externally, like the guys from Jacksonville and the guys from Center City, as well as our visiting professors, we like to talk about career development and kind of how did you get to where you are from where we are, sort of thing, how to get involved in organized surgery, how to get yourself put on committees, how to get to know the people that you need to know to get involved. as you move through stages of your career. Non-core conferences, there's a ton of them. You can't possibly attend all of them and get anything done. I have put together an academic calendar, an Outlook calendar, and since they all have work iPhones, their calendar is connected to their iPhone. And if you set up your calendar to give you like reminders that meetings are coming up, it'll chime for you like 15 minutes before your conference. And then if you're either not doing anything or doing something that you can come back to, you can sort of stop what you're doing and see if you can go to conference. Obviously, when you're on service, you're expected to be there. Some of them are service line based, like breast cancer, trauma, GI is colon and esophagus and stuff like that. The bariatric program is pretty active because of the fellow. We're required to have a bunch of stuff, but the residents are pretty engaged in that too. And then there's other stuff like, educational stuff, the program evaluation committee, the GMEC, um, and uh, and then there's some quality meetings that I also invite the residents to. The GME has a core curriculum which goes over things that are relevant to kind of all residents and not just surgery residents. So that's stuff like, learning about malpractice, learning about contracting. They just did a thing last week where they had a consultant come and provide free appointments to meet with learners and talk with them about their debt, their student loans, and how those things could be restructured to save some money. So the GME provides some cool stuff too. All right, now my baby. Let's talk about HeartNet Health. So HeartNet is the Chiefs, or also known as the Chief Service, and HeartNet is really an opportunity in a medical legal landscape where it's very challenging to provide adequate autonomy for surgery residents. This provides sort of a reserved space for that to happen. The Chiefs Clinic provides care to uninsured and underinsured patients. The chief residents, the PGY5s, have dedicated time every Thursday afternoon. They can be doing nothing on Thursday afternoon other than going to clinic. That's what they do. PGY4s run the rest of the house. They see patients autonomously down there. That includes new patients, that includes post-op patients, that includes follow-up patients, and basically they run the show. They determine whether they counsel people. They determine whether people need an operation or want an operation. They make sure that they're adequately prepared for surgery before they go. This is all, of course, supervised, but it is indirect supervision, which means that we, the faculty, are not physically there. If I am staffing clinic, which I'm often am on Thursday afternoon, I have to be in the building because if they call me and ask me to come down and see something, I need to be able to respond. If they call me and ask for advice or what I think about something, then we talk through it. But for the most part, they see patients and they send me their notes and I review their notes and I sign off on them. If they decide that they want to operate on somebody, they again ensure that patient is prepared for surgery. They sign the consent with their name on it first, the resident's name on it first, / the attending's name. They get to choose which faculty member they would like to do the case with. They call me up and they say, hey, I want to do XYZ. I say, okay. And then it gets put on the OR schedule. They have protected time both in the endo suite as well as in the OR. I call it Chiefs Friday. It's actually blocked under my name, but it's their time. And I and most of the faculty very much encourage them to do as much of those cases autonomously as possible. On Chiefs Friday, I usually bring a bunch of other work to the OR and I sit in the back of the room and do my work while they do the case. On Friday, the chief did an inguinal hernia and I said, show me the cord when it's skeletonized and show me your mesh when it's sewn in. And I looked over her shoulder to see both of those things. The rest of the case she did with a PGY1. The other important piece is that they have a dedicated office staff. Like this is their office. They have their own MAs. They have their own manager. They have their own scheduling staff. And when you look at some of the literature, some of the surveys that have looked at whether graduating residents are comfortable in going out into the world, without a fellowship, oftentimes it is not the clinical piece that they're worried about. It's that they haven't learned about all this other sort of logistical stuff. And so when you have dedicated office staff, you find out what happens if you forget to tell your OR scheduler that you're going on your vacation. You find out what happens when, one of your co-chiefs calls out sick. Somebody else has to pick up those patients, right? You learn things like dealing with insurance companies and what's the difference between a prior auth and a pre-cert and the obstacles that get in the way of people getting to your office, especially if they're impoverished, the obstacles that get in the way of people getting to surgery. What do you do when somebody shows up with their electric bill that's going to get their electric shut off and they just had surgery 2 days ago in the middle of January? Dealing with those kinds of things is important. And I will tell you that it's one of the most common things when we talk to our graduates about the best part about the program and that prepared them the most for the world, is the Chiefs Clinic experience. You can see some of our numbers here. They fluctuate a little bit, but it's almost always above 150 elective cases. Also, keep in mind that if you walk into the emergency room and you're uninsured or underinsured, that case you will still be the chief of that case. But and those cases will follow up in HeartNet, but they're not included in these elective numbers. There's probably double as many cases, including the emergent cases, since those patients often don't present for elective workup. I won't call it a rotation, but we do have a global health experience. Dr. Seth Newman, where's Seth? Right here in the middle. Dr. Newman, for many, many years, through his organization, has been taking a multi-specialty team. They were going to the DR for a good long while, and then unfortunately that got shut down by COVID. Just this past year, they were able to resuscitate this group and take, I think it was family med, OBGYN, internal medicine, and surgery. They all went to a place in Honduras and resuscitated this experience. They almost always take 1 or 2 residents per class. So this is Dr. DiLiberto, one of our chiefs from last year. It sounds like this is ramping up. They actually ended up doing a second mission last year. They're getting ready to do another one this year. And then I'm actually going on a separate mission trip in April that, if it works out okay, next year I'll be able to bring a resident with me too. So this experience is expanding a little bit. Obviously, everybody can't go. It's like a week. We give you the time to go. But that's not enough for all the residents to go. If you are interested in this, my 2 pieces of advice would be: number 1, state your interest early and often. Christian had been talking incessantly about the trip since the day he arrived here, and that certainly bolstered his case. And number 2, speaking some Spanish also helps. Dr. Newman, we have a methodology for selecting the residents that go, but it's certainly helpful if you speak some Spanish. So brush up on your Spanish if you want to go to Honduras. One of our other big selling points is our operative experience. In some of the more traditional programs, you don't see the operating room till you're PGY3, basically. That was certainly my experience. We are not that way. We think that it keeps you motivated to keep learning and keep working in the program if you get more than a little taste of what the end game is. And so the board requires by the end of your PGY2 year that you have 250 total cases. So there's a difference between major cases and total cases. Major cases are basically like stuff you have to go to the operating room for. Total cases include things like central lines, debridement, INDs, things that are done at the bedside, basically. So in looking at our major operations, that's major cases, total major cases for our interns last year, major cases 137. And total cases for those 9 were average 217. So even at the end of their first year, their PGY 1 year, they've almost, and some of them have actually achieved the 250 that they needed by the end of their PGY 2 year. So that's very extensive early experience. Our graduating chiefs this past year graduated with around 1,000 cases. You can look at this number as in a couple of ways, but the way I look at it is I think somewhere around 1,000, 1,100 cases is probably appropriate. There are programs out there that will graduate you with 1,500 cases. I look at that, and I've changed my perspective on this since I did my fellowship, but a lot of those cases end up being surplus to competency. Really, training these days should be around training to competency. And if you've done 300 gallbladders, probably 150 of them were unnecessary. During that time, you should have been doing something else, either another operation that you are not competent in, or learning some non-operative things, spending some more time in office hours, spending some more time in endoscopy, learning other things and not just banging out cases because you like to be in the operating room. There's a little more to being a well-rounded surgeon than maximizing your case volume. We have an extensive group of APCs, and I'm very pleased to announce that we have added 6. Okay, 1, 2, 3, 4, 5. yes, 6 APCs to the Department of Surgery in the last year to support the general surgery vascular team, to support the trauma team, and to support the ICU team. All of these APCs were deployed with the intent to work at the top of their license and to help facilitate the residents spending time in the operating room, spending time in office hours, spending time doing purely educational things, being able to, go to robotic trainings and go to cadaver labs and things like that. So we're very pleased to expand our APC complement, and they integrate super great with the team. Like all of our APCs are awesome. One of the questions I very frequently get is about feedback. How do we provide feedback to residents? Obviously, it's an ACGME requirement, but number one, it's important to me that the residents understand the expectations on each service. There are clearly goals and objectives, which are kind of lofty educational aspirational goals, like you're going to learn how to do a lab chole, and those are the things that we're required to submit to the ACGME. However, I think probably just as important are the service expectations, which is how do the faculty on that service actually expect you to execute? Where do they expect you to be? What kinds of things do they expect you to be doing? Can you epic chat them in the morning, or do they want you to call? What kinds of notes do they want you to write? Those are the sorts of things that if you know what you're supposed to be doing, you don't have to guess and sort of figure it out the hard way. And that allows the faculty to really focus on the educational piece rather than sort of training you to do things their way. So we make sure all the service expectations are clear. We encourage all of the faculty to do BID teaching, which is an instructional strategy. B stands for briefing, which means before the case, either at the scrub sink or while, since we don't spend a lot of time at the scrub sink anymore, or while anesthesia is doing their thing, I have a conversation with the learner and we brief on have you done this case before? Do you know how to do this case? When you've done it before, what things did you struggle with? What things did you do well? What things would you be interested in concentrating on in this particular operation? What evaluations have you gotten before on your performance on this operation? So we get all those things kind of out in the open. And then for me, I usually decide with the learner what pieces of this operation we're going to slow down and focus on. That allows me to move relatively quickly through the rest so that I can slow down and spend the time with you on the piece that you want to work on. I is for the intraoperative teaching, which again is targeted and directed based on the briefing. And then D is for debriefing, which means at the end of the case, we have another conversation where we ask the learner to reflect on their performance, on what went well and what didn't go well. We have the faculty member provide their assessment of, what went well and what didn't go well. Some targeted teaching, salient points, as well as some instruction on how those skills could be improved. So I would tell you to go to the sim lab and get in that Atlas box and practice off angle sewing because you can't get your needle in the driver kind of thing. So very targeted, specific activities to improve you for next time. And then if the resident's comfortable, part of this debriefing is asking, and how was my teaching? Is there a way I could have explained this better? Is there a way I could have set this up for you better so it can be more effective next time? At the conclusion of the case, we now participate in the Simple app, which evaluates the EPAs. We actually bought the whole program so we could evaluate all cases, not just the EPAs. But if you haven't seen it, this is kind of what it looks like. We all have the app. The resident instigates the evaluation. The evaluation comes to me. So this is a hernia that I did with Becky last year. It asks me, how hard was this case compared to previous cases? It asks me, what the resident's participation level was in this case. So the levels are show and tell, which means I did the whole thing and you retracted. Direct participation, which means I helped you a lot through this case. Indirect participation, which means I helped you just a little bit during this case. And practice ready means I was on the computer on the back of the room sending emails while you were fixing a hernia. So this information goes back to the resident. They also do a self-assessment of the same case. So they can see what their thoughts, whether they lined up with the faculty. And this provides a lot of information back to us in administration. Lets me know, is there a resident who's struggling to move along? Do we need to intervene to help that resident move along faster? Is there a faculty member who can't seem to move residents along? If all the PGY5s are still in show and tell, like that's a you problem, not a them problem, we got to deal with that. It also lets me see, I can go back and see for the same cases, all the hernias that Becky's done before. So I can see what the faculty evaluations and comments were. The piece at the bottom, the open-ended feedback, is like literally I can just dictate into my phone and that auto populates. So I can see what the assessments were of that resident for a similar case in the past to help direct what we're going to focus on for this case. ACGME requires end of rotation evals for everybody, so we do that. I think the residents find those less useful than the day-to-day feedback that they get, but it's a requirement, so we do it. Twice a year, we do 360 evaluations. And what do I mean by that? I mean, we go out and talk to the staff in the hospital. We do it by anonymous survey, but sometimes we find that residents don't always behave the same in front of faculty as they do when we're not around. So this gives an opportunity for the nurses on the floor and the nurses in the ICU and the nurses in the PACU and the ER and the ER docs and lots of other folks who have interaction with you to make sure that everybody's meeting their professionalism standards. I find that these are actually really endearing and reinforcing to the residents because like 97% of the feedback is just that they're great. The residents are beloved in the hospital. The nurses love working with them and watching them grow up into young surgeons and are really, really engaged with the teaching program. And so hearing feedback from the nurses about, how great they are at the bedside and how polite they are and responsive they are and conscientious they are really is kind of a morale boost. We have 360s out right now. And then twice a year, of course, we're required to map performance of all the residents to the ACGME 6 competencies. There's something called the surgical milestones, which is kind of like the ladder that you have to climb in all the competencies to complete your residency. And so we determine those in a committee of faculty. We submit them to the ACGME, and then I review them with all the residents twice a year at their semi-annual review, where we go over all of their progress through the residency program. All right, concurrently, we have a very robust quality curriculum. Like I mentioned, all the residents get personalized outcome data. They all complete the IHI Open School, which is kind of very baseline didactic learning about quality. And then we always have a bunch of ongoing group projects. We do have some protected time in the schedule for the group projects. This past year or so, we've been working on projects related to healthcare disparities because that was one of our targets. So we're looking at obesity bias and blood pressure measurement. We're looking at people who are English isn't their first language and their discharge process and their discharge instructions being translated and things like that. We have sort of deconstructed the research curriculum a little bit. We used to do a research boot camp, but after doing it a few times, they kind of got bored with it. So the boot camp has been recorded and it's all stored on our team site for enduring materials so that when you get interested in research, you can go watch the boot camp videos. We did, until very recently, have a lot of IRB and research support. Mary Naglak was our PhD research specialist. She retired in July. That job is currently posted. We are collecting applications right now, and so I expect by the time you guys would get here, we will have that position filled. The upshot of that and the importance of that job, why we fought to replace that person, is because residents' participation in research often waxes and wanes based on what rotation they're on. When they're on nights, when they're on trauma, when they're away, the research kind of grinds to a halt. So the upshot of having a research specialist who's outside the clinical world is that person can kind of help carry water in between those times. We try and group residents together into sort of specialty specific clubs if we can. That way, all the folks interested in colorectal are working on the same paper or papers, and somebody else can pick up and carry a little bit if the senior author is away. So it keeps things moving forward, and you'll see in a couple slides that we actually have really excellent scholarly activity output for a non-university program. Simulation curriculum, I talked about a little bit already. We just ran a new intern boot camp, which is basically designed to raise all boats to the same level, make sure all the new interns hit the ground running with all the skills that they're expected to have. They get 40 hours of protected sim time in the first couple months to get them the skill set they need to be in the operating room. FLS and FES are required by the board. I do ask everybody to do the fundamentals of use of surgical energy program out of SAGES. I think wearing my quality hat, that this is really important for patient safety. We do specific skill sessions, things like hand sewn small bowel anastomosis, hand sewn vascular anastomosis. Chip Long does a thing on flap coverage. We did emergency airway last year. So specific sim skills that we do during protected time. If there's somebody who needs remediation in something, we can design a module around that. And then we try and do twice a year, either an animate or perfused cadaver lab. We have some local facilities that we can go to for those. And the robotic curriculum, besides the library of stuff that's on that Da Vinci machine, Da Vinci, like one of their three national training centers is down the street at Temple. So every time they run a course at Temple, they always have a couple of spots available for us so that we can send residents down to do the formal Da Vinci training. Wellness curriculum is kind of an ongoing thing. Everybody gets trained in fatigue mitigation and burnout prevention. I think probably the most important thing to tell you about wellness around here is, the residents take care of each other. And I facilitate that. So if you're tired, if you're sick, if you need a day off, need a week off, you just let us know. You need to go home and you're too tired to drive. If you let us know, we'll Uber you home. If you call out sick, somebody is probably the wellness chief is probably going to call you and probably bring dinner to your house. On the fifth Thursday, if there's a fifth Thursday in the month, the residents get a wellness morning. There's no lecture that morning. The faculty, we do faculty development, and they can either go to a doctor's appointment, get their car fixed, go out to breakfast. They usually go out to breakfast. Each resident quarterly can request half a day of PTO. So that's either, until noon or afternoon. If they want to go, get an early jump on the weekend or schedule a doctor's appointment, whatever. That's run by the quality chief. She's also running quarterly events. I think they just did some ping pong thing, or they go on hikes or they go out to dinner. And then, like I said, they spent some time in the pools. They spent some time in my pool. I did a couple of parties this summer. They spent some time in Josloff's pool. USHAC has a big, full-size basketball court in his backyard. Sometimes they go play basketball over there. But all of these are, then there's some funding to support wellness activities as well. So I want to pause here just to talk for a second about types of residency programs, because often what you will hear, especially in the old school literature or community, is the idea of academic versus community. And I want to spend a minute just talking about why I don't think those terms are particularly accurate, because the word academic really means that there's teaching involved. That's what academic means. And clearly, as I've shown you thus far, there's an awful lot of teaching going on at our place. And it's been going on for a very long time. So I don't think the idea of being academic or not is relevant. I think there is certainly a difference between a program like ours and a university program. A university program is, all people who work for the university. Usually they have some side interests, whether it's administration or research or outcomes or whatever. They usually have to have some extracurricular interests that is part of their contracting. They are nearly all employed, and they kind of climb the ranks through, assistant, associate professorships, that kind of thing. So the expectations on those faculty are a little bit different than the expectations on faculty who are in non-university programs. We are university affiliated, but not a university program. We are academic. We do quite a lot of teaching in our house, as you can see. But there are different groups of faculty in our program than what you would see probably in your medical school, a university program, since most medical schools are at universities. Some of our faculty, like myself, I am employed. I'm employed by Jefferson, and I work at Abington Hospital. My practice is owned by the hospital. I am an employed surgeon in the community at a university affiliated place. There are also private practice surgeons in our facility where they own their own practice and they operate at Abington. Some of them operate at other places. In the world of surgery, and all of the surgeons that are out there, particularly in the US, a small percentage of them are university faculty. The large proportion of surgeons out there are either in private practice, although that population is rapidly shrinking, or they're employed surgeons in the community. And so I think our program gives you a little broader view of the options and the opportunities that are out there of where most surgeons end up practicing. And when we look at our graduates, I've looked back at our graduates over the 15 years that I've been here. We do have a handful that are in working for a university. There's one at Temple, there's one at Rutgers, where they are university employed and have a side hustle of research or quality or outcomes. Um, I have some of those things just being at the program that we're at. But the vast majority of our graduates are in the community, are non-university. They are almost all in teaching hospitals. So they are teaching residents, they are teaching medical students, but in places like this, which are university affiliated. Or some of them are not even university affiliated, technically. They are just collaborating sites with the residencies. So to that point, this was our collected scholarly activity from this past academic year that we just submitted. So we had almost 20 peer-reviewed articles. There were 6 that were still pending, 38 presentations at meetings, 4 chapters in surgical textbooks. And I'll tell you, just this past week, because I announced it on Thursday, we had 2 abstracts accepted to the Academic Surgical Congress, which is one of the premier elite academic surgical meetings. And we had one accepted to the Society for Clinical Vascular Surgery, which is one of the top vascular meetings. So there's certainly stuff going on here. If you want to, pipette and kill mice, this probably isn't the place for you, because we don't do that. But we do a lot of clinical research, a lot of outcomes research, a lot of data research, quality stuff. I usually have quality stuff. We published a paper around education stuff this year. So there's plenty of opportunity for scholarly activity on stuff that really has a lot more impact in the real world. Mentorship. One of the big questions that I get every year is about mentorship. Mentorship's a tricky wicket because it means different things to different people, and different residents want different degrees of your involvement in their business. I will say this, that we try and assign all the PGY1s to a chief resident big buddy. Your big buddy oftentimes ends up being your first chief of service, just because they know you. But that person's supposed to make sure that you're okay, make sure that you're adapting okay to the program, make sure that give you tips on getting your feet on the ground and getting organized and staying on top of things and setting you up for success. And then I think, as you spend more time and meet more chiefs, the big buddy kind of wanes over time and ends up just sort of being the people that you gravitate to. The junior residents all get assigned to an associate program director. That associate program director is supposed to mentor them through sort of the stuff that's specific to their class. Whether it's going to CHOP or whether it's, taking their FLS test, like that's the kind of stuff that just getting through the program sort of stuff. Usually by around, I don't know, PGY 3-year, early PGY 4-year, residents start figuring out what they want to do with their lives. And then they tend to gravitate pretty organically to the faculty that are into whatever they're into. We don't really need to do a lot of work around that, because when you have a lot in common with people and a lot of similar interests, they will end up forwarding stuff to you, opportunities, things like that. I get a lot of emails from different organizations looking for residents who want to participate in advocacy or who want to participate in, global health. And so I'll forward those things out. Our alumni are a great resource. As you've seen, quite a lot of them come back to work here. The others that don't come back to work here remember us fondly. And so they participate in panels. They will participate in research with residents from here or projects. Cy Gallagher, who just came to give our alumni grand rounds over the summer, is participating in some research with some of our juniors. But they'll also give you advice on, things you need to know. Should I join the American College of Surgeons resident chapter? What other societies should I be involved in? What opportunities are there for me to get on committees or participate in the world of organized surgery? How do I meet the people that I need to meet to get me to where I want to go? We also send all of our PGY 4s or 5s. They get one Chiefs conference. That Chiefs conference is basically a meeting that you can go to. By the way, if you get something accepted at a meeting, you're the presenting author. We pay for you to go to the meeting. So if you're accepted, you're going. But the Chiefs conference is one conference they all get to go to if they don't need to have something accepted. And so it's usually in their field of interest. And the idea is to go for networking. So that if you're interested in MIS or Barry, we would take you to ASMBS or SAGES. You'd walk around with me or one of my partners, and we'd introduce you to some people to help with your fellowship applications as well as job search down the road. And then we try and send all the PGY4s to. There's a couple of leadership courses, some run by the ACGME, some run by the American College of Surgeons, to learn about things like leading teams. We're going to add a piece into that this year, I think, looking at interviewing, both for fellowships and for jobs, and the kinds of questions that you should be asking. As a part of that, I call it a coding and billing talk, usually in the spring for the Chiefs, but it's more than coding and billing. It's like all the stuff you got to think about as you start to become an attending. Things I wish I did, basically. So where do our folks go? This is our data for the last, 13, 14 years. You can see that compared to the average program, we do put a few more people. I wouldn't call it private practice. I would call it straight into practice, because most of them are not in private practice. They are employed. There's a few of them in private practice. We have a couple of folks who had military commitments. Our board passage rate is good. And then you can see we've put people into a ton of different fellowships. Colon is a big thing around here. Vascular is a big thing around here. Recently, we had a bunch interested in plastics and MIS. So where do they end up? This is where people went for their fellowships. You can see, we are in the Northeast, so they tend to be concentrated. We tend to attract applicants from around the Northeast and residents from around the Northeast. And so, people tend to stay around the Northeast. This is important a little bit, though, because most likely your first job out of fellowship will be someplace close to where you did your fellowship. And so a lot of our folks end up staying in our vicinity. That being said, we have a pretty tight relationship with, like I said, Cleveland Clinic in Florida and Cleveland Clinic in Ohio. We have a couple of people who are on faculty now down in Florida. So there's quite a little cohort. We call it Abington South down in Florida. Every time there's a meeting down in Florida, like 20 Abington people are there. So we've got a lot of ties to Florida. But you can see there's a little sort of smattering all over the country. Again, with a program that's been around for 70 years, that puts a lot of people into fellowships. You'd be hard pressed to go to a national meeting and not find somebody who came from Abington. We have a pretty solid presence across the country, and most people, even though we're not a university program, know about Abington because we've been producing a quality product for a long time. So I want to tell you a little bit about our recently graduated chief residents. This is a couple of years ago. You can see here that Dr. Heilman, who went into colorectal, she's now in Alaska. She called me her first day of clinic on an Indian reservation to tell me that thank God for the Chiefs clinic, because otherwise I would have drowned today. She learned how to run that show and survive because of her time in the Chiefs clinic. Adi Das actually got a great MIS fellowship at Pittsburgh, and since then we have hired him back. He's now my bariatric partner in New Jersey. Luis did his vascular surgery fellowship, and I believe he was just finished, so he was looking for a job, but I believe he took a job on Long Island. Thea completed a critical care fellowship in Jacksonville, and then did some of her military time, and I think she's now, I believe she's signed with Jacksonville to stay there and do critical care. Quinn did vascular surgery. She also, I believe, is back in New York. Importantly, I'll point out about Quinn that she had a baby during her chief year. And I think that's important because also Jamila here in the middle, the next year had a baby during her chief year. So this is something as far as family planning that we are experienced with and that we can work with you on. And it's certainly possible to have a baby during residency. One of our chiefs this year, Adam, his wife obviously had the baby, but he took some time off this summer for paternity leave. So we can make it work. This is a class the year before last. Tashara and Raz, both of them felt like they were comfortable going into practice, and both of them did go into practice. They're both working, doing a lot of robotic work, one in Maryland and one in Missouri. I've spoken to both of them recently, and they're very happy with their career choice. Gab and Jamila both went out into colorectal, both at their top choices, one at Mayo and one at Northside in Atlanta. And Mike Romani is in his second year of vascular at Wayne State, which is a inner city vascular program. This is the crew that just left us. Dr. Myers just started his vascular surgery fellowship at Ohio State. Jaleesa's, everybody else went to Michigan, basically. Jaleesa is doing breast at U of M. Becky is doing colorectal at Henry Ford. Casey is doing colorectal at Michigan State. And then Christian decided that he wanted to do a couple of years of health service research and get his master's degree at Columbia before he completes his surgical oncology fellowship there. So to close, I just want to make a couple of points about, one of the questions I always get asked are sort of what are the best things about your program and what changes do you see coming? So that's kind of where I'm going with this. Every year, we have a day called Frobese Day. It's in the first week of November. And Fro was a chair of surgery for a very long time, like 25 years. And he was also chief of staff at Abington. And he was the guy who really made us an academic center. He founded several of the residency programs and really sort of elevated us out of little community hospital status into a truly academic center. And as a part of that day, there's a dinner. At the dinner, there's some awards that are given, and the award that's given in surgery, you can see here, recognizes skill in the care of patients with surgical disease, leadership, ethical and moral excellence, teaching ability, participation in scholarly activity, strong initiative and self-discipline, empathy, compassion, and surgical judgment. Now that's a mouthful, and that's a lot of independent traits to aspire to. So winning this award is really pretty prestigious recognition. I go out and poll the crowd. Basically, I asked the staff in the hospital, I asked the other residents, I asked the APCs and the faculty, who do you think we should put up for this award? And I want to share this. This is Casey Patterson won the award last year. This is the comments from one of her junior residents. She's had the privilege to work under Casey as a junior resident. During the time I've worked with her, she led her team through vast changes in our curriculum, probably because there was a new program director, and found day-to-day solutions to unanticipated problems expeditiously. She's a servant leader, finding surgical training opportunities for her peers and juniors, as well as making an inhospitable working environment a little more humane. She leads with humility, a surprisingly rare leadership quality. This humility always leads her to a sound and thoughtful clinical surgical judgment that also leads to excellent and compassionate patient care. On top of her leadership requirements, she also takes part in leading a research team on a critical care research project that led to submission of an abstract with an extremely busy schedule. At the end of the day, I would trust her to be my surgeon if my life depended on it. And the day that I gave her this award, I received the following text from one of the mid-level residents. That he's hoping when Casey receives this award, she understands that her leadership, mentoring, and character is truly appreciated and admired. And so why do I bring this up? Because I want you all to understand that the chief residents in surgery are revered in our hospital. They are far and away the best doctors in the building. There's some places where trainees, even chief level trainees, are sort of second class citizens or treated as such, and that is 100% not the perspective at our place. Our chief residents are very highly respected doctors. We are not the kind of place where we sort of shotgun consult everybody to take care of all of our stuff while we operate. We believe in raising well-rounded surgeons who are great doctors and compassionate human beings, and just seeing from that nomination the respect that the junior residents have for the senior residents and their perspective on them. I will tell you that there's about 1 billion things that the hospital wants the chief residents in surgery to be involved in because they have so much respect for them, to the point where I have to pull back and say, like, we can't be at every code. We can't be at every rapid response. Like, I know you want us to be there because they're good. But it's really impressive how our chief residents are regarded in our facility. That's number one. Number two thing about our shop that I think is great, and the reason why I'm still here is because of the camaraderie. Really, we are a place where people take care of each other, and not just the staff taking care of the patients, but the staff taking care of each other, the residents taking care of each other, the residents taking care of the staff, all the way up to the faculty taking care of each other and the staff. It's a nice place to work. It's the kind of place where, like, you'll be here for like 3 weeks and you'll know all the housekeepers' names because they will all introduce themselves to you. You'll know Mark behind the grill in the cafeteria, and he'll know how you want your grilled cheese cooked. If you look lost in the hallway, people will like run at you to ask you if you need help to get you somewhere. It's really bizarre. When I first started here, I didn't understand it. But it's just a really nice place to work. It's like a lot of people in the building didn't realize that this place grew up from a tiny community hospital to be this enormous place, but it still has that tiny community hospital feel. And that cascades to the residency program. The residents, there's 31 of them, so they're not all best friends. But they respect each other and they take care of each other. Like I said, if somebody's sick, they're going to reach out to you. They're going to try and help you. They do Friends Thanksgiving together. They take care of the folks that don't have family nearby. If someone's calling out sick on a weekend, it's not hard for me to find coverage. 2 or 3 people will jump up and say, I'll do it. It's a very cohesive team, and it's a deliberate part of our recruiting strategy to find people who will fit with that team, because hierarchy and competition really throws a wrench in the mix, and we are not, that's not the vibe that we're looking for. That camaraderie extends to the faculty. The faculty hierarchy here is significantly flatter than I've ever seen in a residency program. They like the residents, they like them as people, they get to know them as people. Sometimes they hang out with them as people. This is Dr. Josloff in the Kelly Green coat. Dr. Josloff is a lifelong diehard Eagles fan and has season tickets and is always there, basically. Probably there right now. He likes to take residents to the game, and he in particular likes to take residents to the game who are fans of the opposing team. So on the right there, you can see Dr. Shaddis, who is a graduate, who is now faculty, Dr. Josloff, and then he took 3 of our residents who were all fans of the Dolphins to the Eagles-Dolphins games, just so he could, talk some smack at the game. I believe all 3 of those folks are now back in Georgia's in Jacksonville. I think the other 2 are in Miami. So they're all back, and they're part of the Abington South crew. All right, lastly, so this is last year's graduating class. The last thing that I would say that I think is different and important about our program is the degree of autonomy. And when I talk about autonomy, it's not just in taking care of patients, although that's important, to give you some space to learn and grow and breathe and make mistakes, but not such big mistakes that, I can't catch you when you fall. But they have a lot of autonomy, and I try and give them a lot of autonomy in the running of the program. And there's certain things that I have to keep you between the guardrails to keep us out of trouble, both with the ACGME and the hospital. But there's also a lot of things that I think the residents are adults. I treat them like adults and I expect them to behave like adults. They are not the program director's teenage children. I don't like bossing them around or micromanaging them. I like them to understand what their expectations are and to perform to that level. And so what does that mean? That means they have a lot of control over the schedule. They decide who gets to go on vacation when. I've got chief residents who do that, managing all the time off. They get to decide how many residents are on which service. They get to decide what resident gets assigned to a case. So if I'm doing a bypass on Tuesday, if I want a senior level resident there, I better provide a really good educational experience, because otherwise I'm not going to see a PGY5. So I think that having a modicum of control over their working environment in a place where, none of us have a ton of control when you're in healthcare, especially when you're employed, and within the confines of the hospital needs and the ACGME, residency is 5 long years of when you're trying to come into your own and trying to develop your independent practice where you don't have a lot of things that you can do. I try and give them as much control over those things as possible. But then part of being adults is that you get to live with the consequences. And I think that's part of the learning and growing process in leadership. So let's talk about new things on the horizon. Well, obviously we're going to get a new chair. I have an idea who it's going to be, but I'm not sure, so I can't tell you. But like I said at the beginning, I think having a new chair will bring fresh ideas and fresh eyes. I think the program is strong enough and solid enough that this isn't going to be a major disruption or bump in the road. I think the new APCs being on board, they're still kind of coming along in their training. Some of them just started. My intent is for them to really function at a very high level, almost like, can do most everything a resident can do other than operate. And that will allow us to very specifically fine tune our educational experiences. Like if you've already put in 150 central lines, you probably don't need to put in central lines anymore. And so that can be an APC job, taking some things that are not surgical rotting toes on vascular and whatnot, like those can probably be managed on a non-teaching service. And so as our APCs grow up a little bit and those services develop, I think we'll have an opportunity to really get very granular around optimizing the time that you are in the hospital. It should be educational time where you're learning something. And I think having the new APC cohort will help with that, especially on some of the less operative services like ICU and trauma. Having the APCs to do some of the routine day-to-day stuff will liberate some residents to be able to spend some more time in the operating room. I think there are some adjunctive um, IT things that are coming along that I think we might be able to integrate very well into our processes to try and improve the quality and efficiency. In particular, AI. There's a new AI ambient. Basically transcribes your conversation with the patient. So we're going to do some training around that, and they're piloting it right now. But I think that could really impact the amount of time we spend doing documentation, both in the inpatient setting as well as in the clinic. So all of those things I think are good opportunities. We'll look and see what's going on at Lehigh Valley. That's a little far of a way to commute, but if there are opportunities there, or if there are collaborative resources now that everything can be done virtual, we can share experts with them. We just had a lecture from one of our faculty in Jacksonville. There's no reason why they couldn't have zoomed into it as well. So I'm just going to finish with a quick overview of how interview season goes for us. So I have made the decision to continue doing all of our interviews virtually. And that was a hard decision to make, because while I would love for all of you to be able to come and see us and shake my hand and see our cool hospital, I want to be equitable. And I recognize that medical school is expensive and you're paying for it, and you need to pass your rotations, and time for travel, being away from family, being away from your kids, your spouse, and the costs. I mean, the cost of traveling to interview, I didn't pay it off for a very long time until I wasn't attending. And so I think the fairest thing to not give advantage to those that have the resources is to do it virtually. So on your interview day, we will ask you to zoom into our M&M, which is at 7 in the morning. There's some paperwork you have to fill out to do that, so please get that back to Rebecca. I'd like for you to come to our M&M so that you can see that we very deliberately try and make that an educational opportunity. While yes, we are talking about complications, it is not a shame and blame game. We are there to talk about opportunities for improvement and provide education. And I think that helps you see some of the real life interactions with the faculty that aren't a little bit superficial, which is what happens in some of the social events. You will do an interview day with me and my team, as well as some of the residents. That will also be by Zoom. And then we have 3 resident-led Zoom social events. They usually do like a little presentation on, the stuff that I didn't talk about, the social stuff. And then they have some games that they play with you for you to kind of get to know them a little bit. We only have 3 social events because I can't get residents to come to like a whole lot of things, especially when it's the holiday season as well as pre-in-service exam season. So we only have 3 of them. We ask you all to sign up for one, just so that we can get to know you a little bit, and you can get to know us a little bit. And then this is important. If you want to come and see Abington, you can come and see Abington. We will do an in-person second look day the first Friday in February. On that day, we will have already completed and submitted our rank order list. So this day is entirely for you. If you want to come, you can. If you don't want to come or you can't, then you don't need to. It will have your presence or absence will have no impact on our rank order list. It's entirely for you. We have you come in the afternoon on a Friday. We give you a tour of the place, try and get up to the helipad if we can, because it's a nice view of the city. We have you meet some of the APCs and some of the leadership and hang out with the residents a little bit. We do some snacks, and then they do a social event. Last year, they went down in the city and went and played ping pong, and they loved it, apparently. So I think that's what we're going to do again. But that way, if you want to check out the area, if you're not from here, or if you just want to meet with the residents and hang out, you can do that. But again, that's entirely for you and has no bearing on our rank order lists. So that was a little bit long, I'm sorry, but in conclusion, thank you very much for your interest in our program. This is the old school part of the hospital, very pretty. Thank you for your interest in our program. We look forward to meeting you and learning more about you. Make sure you wrote down any questions that you might have so that we can make sure that we answer them for you. And good luck in your match season. I know it's tough. It's the recruiting and match season is tough. It's a long road. But I promise you, all the programs out there are great programs. They're all just a little nuanced. Everybody meets the ACGME requirements. You're going to be a great surgeon wherever you end up. And so best of luck to you and welcome to the House of Surgery.